Hello everyone and welcome to this INI-CET May 25 recall session of anatomy. I'm Dr. Ashwini Kumar and I will take care of the anatomy part. This INI-CET is again no surprises for the subject of anatomy. At least I can say that the questions, the topics which have always been important are the one which are mainly emphasized on. Though if you analyze this paper a little in detail, then you will see a little variation in the way the questions are being asked or the way the topics are being emphasized on. I mean, important stuff, the PYQs, the PYTs that we keep talking about are there, definitely were there. But when you look at the area from where the questions are being asked, you will see that okay, relatively there is a almost zero to just a very few questions which were asked on the neuroanatomy part. There were questions on the questions on syndrome, but exactly the neuroanatomy based questions were not there. Embryology questions, core embryology questions were not there. But this is where it is very important for us to understand that do not get biased by looking at this one paper, because there are hundreds of example earlier also when you will see that when they generally the topic which are heavily loaded in the INI-CET, which usually are the embryology and the neuroanatomy and head and neck though it was there, and this time it was not there to be seen much. But again, November INI-CET coming up, that again can surprise you, and you can again see the loads and loads of question in that part. So this keeps on happening time to time, that at times they will give a lot of questions from the limbs. Sometimes they give a lot of questions from the neuro part here. But though having said that, because we have the NEET exam close by, please do not get biased or don't start thinking, okay, they're not asking neuroanatomy much or embryology is not asked much. Absolutely not. I mean, these are still the two most important topic in the anatomy, and you have to pay maximum stress to them. So let's start with the questions of the anatomy part. Obviously some overlapping questions were there with the surgery and with the ENT and other part as well. So I'll take the question which mainly correlates to the anatomy part. Like the question number 1, it says that which among these is supplied by the deep branch of the ulnar nerve. Now this question, if you somebody read about the ulnar nerve, it is not difficult, but the whole catch in this question is the word deep branch. Because the moment they said the deep branch of the ulnar nerve, then you don't have to think about the entire ulnar nerve. You just have to think about a specific portion of ulnar nerve which is present in hand, and it is a deep branch. So if you look at the options given over there, if these were the exact options. Now again, having said that, because it's a recall and it is based on the recall of the team of the students, so you may see a little variation in the options. It should not bother you. You should know that what topic is being asked and how these questions are being asked, so that for your upcoming exam you can stress on those as well, regardless of what exactly options were there. So guys, flexor carpi ulnaris, opponens digiti minimi, third lumbrical, and fourth dorsal interosseae. Now these are the 4 options which were provided as per the recall. And I find this question a little interesting in the way, because the deep branch is mentioned, which is just supplying the muscles in hand, and there is one forearm muscle which is also given over there. All the 4 muscles which are given here in the option are supplied by ulnar nerve. But again, is A, B, C, D all 4 are answer? No, they're not. Let's have a discussion on that. Now what you're looking at, it's a palmar aspect of the hand. And let's say the ulnar nerve, guys, once the ulnar nerve, it crosses the flexor retinaculum. As we all know that ulnar nerve passes superficial to flexor retinaculum. And in the hand, it gives off a superficial branch. And then there's a deep branch of the ulnar nerve which is going to supply loads of muscle. Presuming that this is a superficial branch here, I'm writing superficial branch SB, and this is a DB, that is a deep branch of the ulnar nerve. The superficial branch of ulnar nerve, it supplies just one muscle, and that is a subcutaneous muscle of the hand, that is a palmaris brevis. Palmaris brevis, guys, it's a muscle which is present in the hypothenar region. It's one of the hypothenar muscle, but it's a very superficially placed hypothenar muscle. It is just present under the skin, and not much of a functionally important muscle. It's basically a remnant of a muscle called as a penniculus carnosus. There's a muscle present in lower animals, which is like in the animals, that is called as a penniculus carnosus, and we have like a remnant of that muscle left here and there. Like platysma is one of the remnant facial muscles, and palmaris brevis, these subcutaneous muscle, they are remnant of that penniculus carnosus muscle. And it is to be noted that superficial branch of the ulnar nerve, it is just supplying one muscle only, that is palmaris brevis. one of the hypothenar muscle, subcutaneous hypothenar muscle. Whereas the deep branch of the ulnar nerve will take care of the remaining hypothenars. All remaining hypothenars are by the deep branch. And when I say, guys, all remaining hypothenars, I'm talking about the muscle like abductor digiti minimi, the muscle like flexor digiti minimi, and it is also going to supply opponens digiti minimi. So out of the 4 hypothenars, only one, the superficial one, is by the superficial branch. And from here onwards, everything else is by the deep branch of ulnar nerve only. So we have abductor digiti minimi, flexor digiti minimi, and opponens digiti minimi. The deep branch, it also supplies interossei. And when I say interossei, it supplies all interossei, palmar interossei, dorsal interossei. As we know, we have 4 palmar interossei which are unipinnate. We have 4 dorsal interossei which are bipinnate. But all interossei are supplied by the deep branch of ulnar nerve. It does supply the lumbricals also, and it is what lumbrical is supplied by this? It is supplying the 3rd and the 4th lumbrical. I'm writing L3 and L4, 3rd and 4th lumbrical. As you all know that there are 4 lumbricals in hand, out of which the 1st and 2nd lumbrical, or you can say the lateral 2 lumbricals, are unipinnate, and only 3rd and 4th lumbrical, like the medial 2 lumbricals, are bipinnate lumbricals, and they are supplied by the deep branch of ulnar nerve. Well, that is not it. It is ending by supplying the muscle that is adductor pollicis. It's a thenar muscle, adductor pollicis. It's present in the thenar region, and it is the last muscle to be supplied by the ulnar nerve. That's why adductor pollicis is sometimes regarded as the graveyard of ulnar nerve, because that's how the ulnar nerve ends, by supplying the adductor pollicis muscle. In the thenar region, adductor pollicis is one muscle which is supplied by ulnar nerve. And I hope you know that in the thenar region, there is another muscle called as a flexor pollicis brevis. Guys, flexor pollicis brevis is having 2 heads. One is the superficial head of flexor pollicis brevis. And we got a deep head of this flexor pollicis brevis. Superficial head is always supplied by the median nerve, and deep head is sometime supplied by the ulnar nerve. It can be by median, but it is sometime by the ulnar nerve. And then again, flexor pollicis brevis is, you can regard that one more muscle in the hand which is supplied by the deep branch of ulnar nerve is a flexor pollicis brevis deep head, and it's a hybrid muscle. So the question which is specifically on the deep branch, let me highlight that for you. It's the deep branch of the ulnar nerve we are focusing on, and starting from, it is supplying 3 muscle in the hypothenar region, just barring one, supplying all interossei, supplying 3rd and 4th lumbrical, which are bipinnate lumbrical, and it does supply the adductor pollicis muscle, including the deep head of flexor pollicis brevis as well. So you can see dominant nerve of the hand supplying maximum muscle in the hand, and ulnar nerve in hand has always been an important question. So obviously you cannot miss out on that. But I hope that you got the point, because the deep branch of ulnar nerve is mentioned. So if I take you back to these options, you need to be careful with the muscle flexor carpi ulnaris. Guys, flexor carpi ulnaris, yes, it is supplied by the ulnar nerve, but it is supplied by the ulnar nerve in the forearm only. When the ulnar nerve passes from posterior to the medial epicondyle, it enters through the space which is situated between the flexor carpi ulnaris. We call it a cubital tunnel. So ulnar nerve is supplying the flexor carpi ulnaris, no doubt about that, but that is in the forearm only. And at that time, the nerve is not divided into superficial and deep branch. Once the nerve crosses the forearm, I hope you know that in the entire forearm, if this is the medial epicondyle, the ulnar nerve, it passes behind medial epicondyle, and in the forearm, it just supplies 1.5 muscle. One is the flexor carpi ulnaris that we just said. In fact, passing through this tendinous opening in the flexor carpi ulnaris, and it does supply the flexor digitorum profundus medial half, another hybrid muscle. The medial half of flexor digitorum profundus is supplied by that. And after that, the nerve is passing superficial to flexor reticulum. As we just said, it is going to divide into a deep branch and a superficial branch. We just discussed what they are doing. So these are the overall supply of the ulnar nerve. And well, I find this question very important and very interesting, because of the deep branch was specifically mentioned, and they purposefully gave flexor carpi ulnaris in the option. So the answer for this question is opponens digiti minimi, the 3rd lumbrical, and the interossei, all interossei basically. So B, C, and D from the given option, the B, C, and D only, and not option D. If exactly this way the question was asked, so I know that some of the people might have committed this mistake of answering it as D, thinking about the ulnar nerve innervation is asked without realizing it's the deep branch of ulnar nerve which is being asked. Well, that's INI-CET for you. Moving on, the next question, guys, the question next question we are looking at, it says, which among the following muscle are supplied by the superficial part of the or superficial branch of the peroneal nerve, or you can simply say superficial peroneal nerve. Now, before I discuss this question, I wanted to realize one thing, that this is something which we discuss in our regular class and our our revision program also, that the innervation of the upper limb muscle and lower limb muscle, you have to remember these innervation, and especially from the group's point of view. Like even if you don't know the name of the muscle in quite detail, but if you just the attachment of the muscle in quite detail, that is still okay. But it's important to know that what muscle is present in anterior compartment of forearm, what is in posterior compartment, and what nerve is supplying that here. Because this is again a trend which is being seen, that the muscle, the nerve supplying the calf muscle, the nerve supplying the superficial peroneal nerve, like it is asked in here, the ulnar nerve supplying in the hand, and similarly that gives you a hint that for the upcoming examination, be it INI-CET or NEET exam, every compartment of the upper limb as well as lower limb, you should know that what are the overall muscle in that compartment. You should have a broad idea about them. Obviously, the action of some of the muscles are important, which we keep talking about. The important muscles are being asked in the exam. Like you'll see one of the question coming up on that part as well. And the nerve supply, the innervation of those muscles. So at least in the group, like for example, all the extensors at the back of the forearm, they're supplied by the posterior introitious nerve. So even if you can make out, okay, what are the extensors? The name says extensor. Extensor could be extensor pollicis longus or pollicis brevis, and I know it is at the back of the forearm and supplied by posterior introitious nerve. I'm pretty sure that we'll be able to take care of the questions like these here. So knowing the compartments, a muscle, and the innervation. Even I would suggest you for the upcoming examination also, that just make a list of all the compartments and just write down, okay, what is the nerve supplying them? Anterior compartment of the arm, musculocutaneous nerve, like what is the posterior compartment is by the radial nerve. A broad picture is important. And the exam like INI-CET or sometime obviously NEET also, they might ask you the question a little more detail, which goes into the hand and foot. So muscle of the hand and foot innervation is also which is being asked. Okay, question says that which among the following is supplied by superficial branch of the peroneal nerve or superficial peroneal nerve? Well, again, first, it's important to know that what are the muscles that we have in these different compartments, the three compartments in the leg, and what superficial branch of peroneal nerve is supplying which of them. So let's have a very quick discussion on this. So guys, if this here is the popliteal fossa, let's presume we are looking at the popliteal fossa, obviously from the posterior side. The sciatic nerve in the very much upper part of the popliteal fossa divides into tibial nerve, and then there is a superficial peroneal nerve, guys, superficial peroneal nerve, which I'm sure you all know, that which winds around the neck of fibula, and then it divides into a deep peroneal nerve, which is supplying the anterior compartment, and superficial peroneal nerve, which is going to supply the lateral compartment of leg. So it's the sciatic nerve, which is very much in the upper part of the popliteal fossa. It divides into this tibial nerve. So one major nerve here we have is the tibial nerve, which is supplying the muscles of the posterior compartment. It's very important to keep it in mind that the nerve belongs to which compartment, so that it will be easy for you. So tibial nerve is the nerve for what compartment? I'm writing posterior, guys. It's for the posterior compartment of leg, the calf muscles. Then you can see this common peroneal nerve, which is winding around the neck of fibula, dividing into this superficial peroneal nerve. And the one which is a nerve for the anterior compartment, that is a deep peroneal nerve. So deep peroneal nerve is the nerve for the anterior compartment, the muscle which are present on the anterior compartment of the leg, and superficial peroneal nerve, which is supplying the lateral compartment. Well, that's the three compartment we have in the leg. We got posterior, we got lateral, we got anterior compartment. As we said, the tibial nerve is supplying the posterior compartment, guys. So let me start with the muscle which is present within the floor of the popliteal fossa. That is the popliteus muscle. It is going to supply popliteus. It is going to supply the gastrosoleus. When I say gastrosoleus, I'm talking about gastrocnemius and soleus. Well, we do have a muscle that is plantaris. So gastrocnemius, soleus, and plantaris. Gastrocnemius, soleus, and plantaris, these are superficial muscles which are present in the calf region. So superficial calf muscle. Now deeper calf muscle, which are basically flexors, because these muscles are going to reach till the digits or to the bones in the foot region. Gastrosoleus and plantaris, they will not go beyond calcaneum. They will just insert on the calcaneum by tendo Achilles. But the deeper muscle that I'm now talking about, which are also supplied by the tibial nerve, includes the muscle like flexor hallucis longus. We got a flexor digitorum longus, We also got a muscle that is a tibialis posterior. It's a tibialis posterior. It's present on that. So these are the deeply placed muscle in the posterior compartment, that is flexor hallucis, flexor digitorum, tibialis posterior. So this is about the tibial nerve supplying the posterior compartment. After common peroneal nerve winds around the neck of fibula, which is a very common site for the injury of the nerve as well. And they do ask this question about the common peroneal nerve injury. Superficial peroneal nerve supplies two muscles which are present in the lateral compartment, and the two muscles are peroneus longus and peroneus brevis, guys, the two everters of the foot, that is peroneus longus and brevis. Whereas the deep peroneal nerve is known for supplying the muscles of anterior compartment. And when I say anterior compartment, we are obviously talking about the extensors. So we have a muscles like extensor hallucis longus. There is a muscle like extensor digitorum longus. We got a muscle this time tibialis anterior. It's the anterior compartment. It's tibialis anterior. And here's the catch of this question. The muscle called as a peroneus tertius. Peroneus tertius, guys. Please be careful with this muscle here. Now, peroneus tertius, the word peroneal might take you toward the lateral compartment, but remember, peroneus tertius is a muscle of the anterior compartment, and this muscle is also called as the fifth tendon of extensor digitorum longus only. It's a fifth tendon of this extensor digitorum longus. Okay, so now knowing that, what are the muscle nerve present in three compartments of the leg, we can make out that what muscles are being supplied by them. So guys, let's fall back to the options here. So it says that which of the muscles supplied by the superficial branch of the peroneal nerve, or superficial peroneal nerve in can say. So it is definitely the peroneus longus muscle, and it is peroneus brevis. And just be careful about the peroneus tertius and extensor hallucis longus are not supplied by them. Both of them are the muscle of the anterior compartment, and they are supplied by the deep peroneal nerve. So answer from this is A and C. A and C is the right answer for this question. Moving on, the next question we got. Well, this is a question again, no surprises there. Although it's not common for the examiner to ask the questions on the origin of the muscle, because it's generally the insertion which are usually being asked. But see, what you're looking at, which of the following is the action of the muscle attached to the marked structure? What is the marked structure? That is a sacrum bone you're looking at. And it's first very important to make a decision that whether you're looking at the sacrum from the dorsal side or looking at the sacrum from the ventral side. So guys, it is obviously the dorsal aspect of the sacrum. You can clearly see all these spine over there. So it's the dorsal sacrum of the region of the sacrum. And there are a couple of muscles that you will appreciate present on the dorsal side. Well, we have a U-shaped muscle origin here, that is for the erector spinae muscle. We have another muscle which is originating from this region, that is called as a multifidus muscle. And these muscles are the back muscle. These are the extensors of the spine, multifidus, erector spinae. And I'm pretty sure that these are the muscle which I'm very sure, in fact, they will not be asked in the exam, because we don't read about these extensors of the back in that kind of detail. But obviously the lower limb muscles, the gluteal muscle has always been important. Now, gluteus maximus muscle, well, the name says it, maximus muscle is having the maximum area which is occupied by this attachment also. It's a huge muscle, guys, gluteus maximus. And if you look at the origin of the gluteus maximus muscle, now let me show you the picture, and so that we can make up your mind. Look, if you look at the gluteus maximus muscle, this muscle that is gluteus maximus here, it is taking origin from various areas. It is taking origin. If I just put if I just draw this iliac bone here, so here's the iliac bone, and presuming that the sacrum and coccyx will be like here only. So it does take this muscle. It does take origin from the take origin from the. I'm just talking about the origin first. So from the posterior and lateral aspect of the gluteal surface of the hip bone. So it's the posterior lateral surface, or I should say gluteal surface of hip bone, right? That's one. There are gluteal lines present, so it is behind the gluteal line. Then it does take the origin from the sacrum that you're looking at actually. So sacrum. It even takes origin from the coccyx. It takes origin from the sacrotuberous ligament also, guys. The ligament which is stretching between the sacrum and the ischial tuberosity, the sacrotuberous ligament. And would you surprised to know that this is also taking some origin from the thoracolumbar fascia as well. It's a big muscle, guys. It's a big muscle. It does take origin from the posterior lateral surface, gluteal surface of the hip bone, sacrum, coccyx, sacrotuberous ligament, and tensor fascia, thoracolumbar fascia. And then the muscle is going to get inserted. This is all origin. This is all origin. The muscle is going to get inserted at 2 important points. One, it is inserted into the iliotibial band. Some fibers are inserted to the iliotibial band, and we do have some muscular attachment also, or this some bony attachment also to the gluteal tuberosity. So there is a gluteal tuberosity also where it is inserted. Gluteal tuberosity was also, it is also one of the question asked, guys. Gluteal tuberosity is also one of the question asked earlier in the exam, that gluteal tuberosity was a picture of the femur was given from the dorsal aspect, and they asked that what is a muscle which is inserted to that the gluteal tuberosity. So gluteus maximus was the question here. So that is an insertion of this, the gluteus maximus muscle. So iliotibial band and gluteal tuberosity is the insertion. Now, this gluteal muscle, guys, you cannot take the gluteal muscle lightly. Not only this one, even gluteus medius, gluteus minimus muscle, because the questions on the Trendelenburg test, the questions on the abduction, the pelvic drop, action of these muscles is something which is not new. They have been asking these questions over and over again, and we keep saying that please just don't rely on the previous year questions. You have to look around the previous year topics. So if you look at the history, the last 5-6 years of this examination, be it INI-CET or even the NEET exam, that gluteal region is definitely important. So if you're investing a little more time in understanding the gluteal region, the nerves and the the muscles, and especially the actions of the muscles around the hip joint, it is definitely will be fruitful. So that's about the muscle attachment here, first thing. So making sure that this muscle that you're looking at, guys, that this is the gluteus maximus muscle which is present here, and you can see that this attachment is extending toward the coccygeal vertebrae also. So this is first thing first, it is the gluteus maximus. The muscle is gluteus maximus. Now whatever the options were given, let's say that if the options were given like this, I mean, based on the trying to have a correct recall, but if these were the options given, then the gluteus maximus, one of the main action of gluteus maximus, undoubtedly, which I'm pretty sure everyone knows, that is the extension at hip. The moment you identify it is a gluteus maximus muscle, options C and D are out of the picture completely now. They are the actions at the knee joint. So flexion at the knee joint, extension flexion at the knee joint will be done by the hamstring muscles, right? Hamstring will do that here. Extension at the knee joint will be done by the quadricep muscle. That is done by the quadricep muscle. So that is anyways out of the option. So we have to fight between option A and B here. So extension at the hip is one function. It is also called the stair climbing muscle. If you keep your one foot on the stair above, and when you pull your body up, then at that time, especially gluteus maximus is quite active, and that basically pulls your body up. So it's a muscle for the extension. The gluteus maximus muscle is known for its external rotation capabilities. The fibers are quite horizontally placed. If I just take you back to the picture again, look at these fibers, especially the lower fibers here. They're quite horizontally placed, and they will help in the external rotation. This is where it is important to know the gluteus medius and minimus are the internal rotators. This is where again they can ask you the question, if the gluteus medius and minimus were asked, which are basically inserted onto the greater trochanter. This muscle is not on the greater trochanter. Those are inserted on greater trochanter. They help in the internal rotation or medial rotation. So this is for the external rotation. So again, option A is out of the option. The medial rotation of the hip, it is done by the gluteus medius and minimus. But when you say abduction at the hip, now we'll say the abduction at the hip is also done by the gluteus medius. If I have to take the one of the main muscle causing the abduction at the hip joint, and which is the main reason for the Trendelenburg sign also, if the muscle is not working, then it is the gluteus medius muscle. But guys, please understand that uppermost fiber of gluteus maximus muscle, once again look at the picture. If you look at these uppermost fiber which I'm highlighting for you of the gluteus maximus, they are also helping in the abduction at the hip joint. So gluteus maximus muscle, apart from its extension, external rotation, upper fibers are also helping in the abduction at the hip joint. And according to Gray's Anatomy, they are the very strong abductors in the upper part. So yeah, you cannot ignore their abductory function. So the answer for this particular question is the abduction of the hip joint based on the option given. And the muscle which was given on the dorsal surface, that definitely was the gluteus maximus muscle. If this picture would have been from the anterior aspect, all I'm saying, guys, let's say if you're looking at the sacrum from the anterior aspect, then the muscle that they probably would be asking you in that region, either they will ask you the iliacus muscle, because iliacus muscle is to be seen slightly in the upper part somewhere here, or they will ask you this E-shaped origin. If you see a muscle which is having an E-shaped origin like this, that muscle is piriformis. That muscle is piriformis. But remember that first of all, it is a view from it's a ventral view. So if you look at from the ventral aspect, if the E-shaped muscle origin will be seen, that will be for the piriformis muscle. And piriformis muscle is an external rotator at the hip here. It is also one of the external rotator, like many gluteal muscle which are present deep to the gluteus maximus. Many of them are external rotator. Piriformis is also one of them. So I believe that if they give you the question like from the dorsal aspect, then the muscle important muscle is gluteus maximus. But if they do give it from the pelvic surface or the anterior aspect of the sacrum, then it is the piriformis muscle you need to specially check out on, that is having an E-shaped origin. Okay, moving on. The next question, which is which of the following cranial nerve is not involved in olfaction? Now, this is again a repeat question, guys. Exact same question, same option. It was given earlier, and we say that this is a little, a question. I should not say it's a controversial question, but it is a question which is not. It is based on a very deep understanding of the olfaction. So at times they go a little beyond the scope of, little beyond the level of the question which should be asked to the graduates, but that's okay. I mean, if people are calm enough and smart enough, you still will be able to answer this question. And based on the recall, I know that most of the people have marked this question correctly, because first, see, let me just put it this way. There is undoubtedly facial nerve, glossopharyngeal nerve, and vagus nerve. These nerve, when it comes to the taste sensation, I'm saying taste sensation, then these are the nerves that we talk about: anterior 2/3, posterior 1/3, most posterior part, the taste sensation. Here the question is about olfaction. That is about the olfaction. In the olfaction, olfactory nerve is something which obviously is important here. Now, olfaction and taste, they go side by side here. And olfaction and taste, if they go side by side, so I can say that vagus nerve, glossopharyngeal nerve, they do have, and even facial nerve, like especially chorda tympani, because that is for the taste sensation, that is also playing the part in the olfaction. That kind of enhances the olfaction, guys. If the taste is there, that enhances the olfaction. Trigeminal nerve is also there, because it is believed that trigeminal nerve is also having, see guys, trigeminal nerve is basically known for detecting the pungent or the irritating odors. Irritating odors. And when I say irritating odors, I'm talking about like irritating odors in the nasal cavity. That is like, can basically detect it here. So pungent odor and irritating odor, they can be detected by the branches of the trigeminal nerve, which are supplying the nasal cavity as well. So the only option left is a hypoglossal nerve here, and that obviously is the right answer to this question. Moreover, here, hypoglossal nerve is a purely motor nerve. Hypoglossal nerve is a motor nerve. So anyways, the moment the word you said olfaction, which is a sensory function, how can you have a motor nerve contributing to it here? Vagus nerve, glossopharyngeal nerve, and trigeminal nerve, they are mixed nerves. They do have a role to play in the pathway. Even vagus nerve also, guys. Vagus nerve basically is in the overall olfaction. It is said to have a role to play in the olfaction, in understanding olfaction, and in especially when it supplies the upper laryngeal region. That is, it can also again detect the irritating odors there, and can elicit the reflex based on that. So vagus nerve, glossopharyngeal nerve, trigeminal nerve, and even facial nerve, they directly and indirectly have a role to play in the olfaction. But when it comes to hypoglossal nerve, it's a purely motor nerve, just for the tongue muscle movement and nothing else. So that cannot be the answer to this question. So answer for this question, a previous year question, and the answer is the hypoglossal nerve. The next question, guys, the question which never gets old, and this is something which we even keep talking about in our classes, that the muscles of mastication, and I always say this, that when you talk about the muscles anywhere in the body, like I have to keep the muscle of mastication on the top when it comes to the PGME questions here, not just for the INI-CET, again for the NEET exam also, these muscles are important. And somehow INI-CET and before previously AIMS, they just love asking muscle question on the lateral pterygoid. Their favorite muscle to ask is lateral pterygoid, whether it is about the action or about the attachment or about the articular disc or about the anterior dislocation. Something about the lateral pterygoid is and they love about it and they keep asking it. Now, what you're looking at in the picture first, and then let's understand that what muscle are we talking about and what is the best option to choose from the given. So guys, the area which is shown over there is a lateral pterygoid plate. Now there are two plates, which is an extension of the sphenoid bone only. We have a lateral pterygoid and the medial pterygoid plate. Lateral pterygoid plate is giving origin to both lateral pterygoid as well as medial pterygoid. Please understand this, that when it comes to the pterygoid plate, we have a medial pterygoid plate and we got a lateral pterygoid plate. Now medial pterygoid plate, it is not providing attachment to the muscles of mastication. Medial pterygoid plate, especially the pterygoid hamulus, it is giving attachment to the superior constrictor, guys. Upper fibers of superior constrictors are attached to it here. So that medial pterygoid plate, in short, it is having no relation to the lateral pterygoid, to the muscles of mastication. It's the lateral pterygoid plate, which is, if I talk about the two surfaces, we got a lateral surface, which is basically seen in this picture, and we got a medial surface. Lateral surface is for the lateral pterygoid muscle, and the medial pterygoid is for the medial surface is for the medial pterygoid muscle. So it's the lateral surface of lateral pterygoid plate for the lateral pterygoid muscle, and medial surface of lateral pterygoid plate, again, that is for medial pterygoid muscle. So first of all, the plate which is mentioned over there, it's lateral pterygoid plate, and both medial and lateral pterygoid muscle will originate from that. But on the lateral side, as you can see, it is shown on the lateral side, then it's the lateral pterygoid muscle which is originating there. The speciality of the lateral pterygoid muscle, let me just show you one picture for the discussion. Now look at this, guys. You can see the various muscle of mastication there. Now this is where the lateral pterygoid plate is present. And the muscle that you're looking at right now, this is the lateral pterygoid muscle, which is actually being asked. I hope you can even appreciate a muscle which is descending from the medial surface of this lateral pterygoid plate. Guys, look at that muscle over there, the one which I'm pointing at right now. This is the medial pterygoid muscle. That is the medial pterygoid muscle. Now, lateral pterygoid fibers, they're running backward. And once they're running backward, the muscle is inserted to the neck of mandible. You can see the insertion of the muscle. If I look at this muscle, it is inserted to the neck of mandible. It is inserted to the neck of mandible, and it is also inserted to the capsule of TMJ. It is also inserted to the capsule of the temporomandibular joint. And I hope you also know that the lateral pterygoid muscle inside the TMJ cavity, it is having an extension called as the articular disc, which is also one of the PYQ, guys. Articular disc, it's a fibrocartilage, and that articular disc inside the TMJ cavity, it is an extension of the lateral pterygoid tendon only. So if the lateral pterygoid muscle, which is basically running in this way, it is like running more like in the horizontal way, the muscle is presumed to have a action of taking the mandible forward and downward, and depression. What is depression, guys? Depression is basically opening of mouth. Depression or opening of mouth is the major function of the lateral pterygoid muscle. Depression or opening mouth is a major function of the opening mouth. And let me quote one statement from the Gray's Anatomy on this, which says that protrusive movement alone has a little or no function except to assist in the opening. So protrusion is a function, no doubt about that. Protraction or protrusion is a function of lateral pterygoid, but in the opening of mouth, it has little or almost no function in that depressive movement or the opening of mouth, which is a major action of this muscle. So if you have to choose the lateral pterygoid muscle, which is having two action, we're talking about the bilateral action, guys. That is when both side lateral pterygoid is working. The lateral pterygoid muscle is mainly responsible for depression. That has to be your best answer. That is opening of mouth. And your second best answer will be the protrusion. Protrusion, or you can say protraction here. So if I fall back to the question here, this is the lateral pterygoid plate, lateral surface, lateral pterygoid muscle is originating there. You can see depression is given in the option, traction, elevation, rotation, all are given in the option here. But depression is definitely the most important action here. If the muscle is working unilaterally, now when we talk about the muscle of mastication action, then obviously the answer for this question is A. But when we talk about the muscle of mastication, we generally talk about the bilateral action. The pterygoid muscle, lateral pterygoid, even medial pterygoid also, if only one side pterygoid is activated, if I only contract the lateral pterygoid of, let's say, one side, it will deviate my jaw toward the other side. Like if you can see my jaw deviated toward the left side. This left deviation of the jaw is done by the contraction of the right pterygoid muscle. So unilateral action of pterygoid muscle is the deviation of jaw. All I'm saying is, guys, when you get a question like this, so when they ask the muscle of mastication action, we have to presume they're asking the bilateral action, unless the unilateral action is mentioned here. So I simply say, what is the action of the marked muscle in that region? They did not say unilateral, bilateral. So we presume that we're talking about the both side lateral pterygoid muscle contracting together, what it is doing. But if this question would have been that, okay, unilateral action of the marked muscle, then obviously the deviation of the jaw, or what do you say, the turning the jaw toward the other side, that would have been given in the option, and that would be the better answer in that case. So this is about the muscle given, lateral pterygoid. Well, already this question is like fourth or fifth time they're asking this question, fifth time if I'm not wrong, a question on the lateral pterygoid, and I'm talking about only AIIMS and INI-CET, which is asking this lateral pterygoid muscle over and over and over again. Okay, chalo guys, next. It says a middle-aged lady choked while eating fish and has associated symptoms of choking, hoarseness of voice, foreign body sensation in the throat. On examination, the fish bone was lodged in the piriform fossa. What nerve is responsible for irritation? I'm pretty sure that nobody got this question incorrect here. We keep reading about this piriform fossa, and that's the same example we keep giving. That is the fish bone getting lodged into it, and while removing that fish bone, or the nerve which is present in the floor of the piriform fossa might get irritated. Now, let me tell you a little about the piriform fossa by showing you the picture, and then we'll come back to this to the options which are given here. Well, guys, if I take this image for the reference, look, as I'm sure that you can all appreciate, this is the inlet of the larynx. And when you look at the inlet of the larynx, somewhere from here, from the arytenoid to the epiglottis, this fold is called as a airy epiglottic fold. That's a airy epiglottic fold is there, airy epiglottic fold. So airy epiglottic fold is present on the medial side of the piriform fossa we're talking about, guys. So it's on the medial side. If I take it toward the lateral side, well, lateral side more anteriorly, though I cannot see that anterior part here, so I'm putting a dotted line there. Lateral wall is by the thyroid cartilage and thyrohyoid membrane more anteriorly. And look at this, the one which is a reflected part of the pharyngeal wall, guys. It's a posterior wall of pharynx which is open like this. Obviously, you're looking at the larynx and pharynx from the posterior side. So this is the posterior pharyngeal wall. This is the posterior pharyngeal wall you're looking at. So thyroid cartilage and thyroid membrane, they are present more toward the lateral side. And posterior pharyngeal wall, it is, the name says it all, posterior pharyngeal wall is more toward the posterior side. So that's how the space which I'm highlighting for you is trapped inside. That is the piriform fossa. So guys, this is the piriform fossa. And the nerve that you see which is present in the floor of the piriform fossa, it is passing deep to the mucous membrane, the nerve which is piercing thyroid membrane and coming inside. Now, you know, the nerve piercing thyroid membrane coming inside is to supply the larynx above vocal cord, and that nerve is the internal laryngeal nerve. That is the internal laryngeal nerve. So guys, internal laryngeal nerve is the nerve which is basically the only structure you will see present deep to the mucous membrane in the piriform fossa. And if any fish bone or any foreign body object which can get lodged here, and let's say while trying to remove that object, there could be injury to this internal laryngeal nerve. And injury to the internal laryngeal nerve, what will happen? The sensory loss will be there in the upper part of the larynx above the vocal cord, and that will lead to the loss of cough reflex. And guys, if there is a loss of cough reflex, well, that can very well lead to the aspiration. So that's the whole idea of knowing about what nerve is present there. So piriform fossa, also called a smuggler's pouch. In older days, people used to smuggle object by hiding inside, something you should not try. And the nerve which is passing deep to that mucous membrane is an internal laryngeal nerve, and the loss of cough reflex will be there if it is injured, and that can lead to the aspiration. So taking back to this picture, so that's a piriform fossa, and the boundary of piriform fossa you're looking at. This view is from the posterior side, and the posterior pharyngeal wall is open. So yeah, it's a simple and straight question. The answer for the question is the internal laryngeal branch of superior laryngeal. I hope you know that superior laryngeal nerve, it divides into the external laryngeal nerve and one is an internal laryngeal nerve. The internal laryngeal nerve is the answer to this question, which is a sensory nerve supplying the mucosa of the larynx above vocal cord, whereas external laryngeal nerve is a motor nerve which is supplying the cricothyroid muscle, the muscle which is present outside here. So it's the internal laryngeal branch of superior laryngeal, which is the right answer. Moving on, again a question which has always been important, and it is important because the dural innervation. When you look at the cranial cavity, guys, the only thing which is innervated is dura mater. There is no nerve supply to the pia mater. There is no nerve supply to the arachnoid mater. We do not have a nerve supply to the brain. So that's why the brain surgeries are painless surgeries once you cross the dura mater part, of course. So dura, when inflamed under the part marked, like basically they've just put the arrow on the posterior cranial fossa, and the question says that the arrow marked area, the nerve supplying in this region, if the dura mater is inflamed in this region, that pain will be referred to what part here. So when you think of overall cranial cavity, guys, the anterior cranial fossa and middle cranial fossa, trigeminal nerve are supplying them here. Before I go to this part, if I may very quickly tell you this, if you look at the cranial cavity, and let me just divide this cranial cavity into 3 cranial fossa, that is anterior, middle, and posterior. Now, anterior cranial fossa is the one which is supplied by all the 3 divisions of trigeminal nerve. You know that it is having a branches of ophthalmic, maxillary, and even the mandibular nerve branches are reaching to supply that region as well. So ophthalmic, maxillary, mandibular nerve are supplying it. Different branches, obviously, we have, like, we call it a meningeal branch of maxillary nerve. We have ethmoidal nerves coming from ophthalmic. Nervus spinosus is a branch coming from mandibular. But the point is, all the 3 divisions of trigeminal nerve supplies the anterior cranial fossa dura mater. Middle cranial fossa dura mater is supplied by the maxillary nerve and the mandibular nerve. Maxillary mandibular nerve. So clearly trigeminal nerve is a dominant nerve supplying the dura mater. But when it comes to the posterior cranial fossa that we're looking at here, if I may just point out here as well, guys, posterior cranial fossa, the innervation which is generally explained here is like what nerves are supplying it near the foramen magnum and away from foramen magnum. Now, guys, the nerve which are going to supply the dura mater, like near the foramen magnum, it's a C2 and C3 branches, the cervical nerve branches, like this C2 and C3 nerve. The cervical nerves are supplying the dura mater in the posterior cranial fossa. And even, we also have again C2 and C3 branches supplying the dura mater of the posterior cranial fossa away from foramen magnum also, and that is via vagus nerve and hypoglossal nerve. So you will see like C2 and C3 branches, they are running via vagus nerve, and then again we have a C2 and C3 nerve which are running via hypoglossal nerve. And this is where it is important to understand, guys. Again, look, how hypoglossal nerve is a motor nerve. Hypoglossal nerve cannot supply the dura mater. It's the C2 and C3 nerve via hypoglossal nerve, they are supplying the dura mater. Similarly, we have a C2, C3 branches, they are also supplying the dura mater via vagus nerve branches. So basically these nerves will join these nerves and they go back into the cranial cavity and they do supply the dura mater. So overall, the dura mater of the posterior cranial fossa is either supplied directly by the cervical nerve branches C2, C3, or they will use some of the C2, C3 branches will use the vagus and hypoglossal nerve to go back into the cranial cavity and to supply the dura mater. And this is the whole crux of this question, because had it been the anterior cranial fossa or middle cranial fossa, and then the pain would have been referred to the forehead region. Pain can be referred to the vortex region here, because ophthalmic nerve branches will come out like this, supplying the forehead region and this region also, right? So you may have a referred pain in this area if the dura mater of the anterior or middle cranial fossa is inflamed. But because it's a C2 and C3 nerve, and guys, greater occipital nerve is having a dermatome of C2, which is supplying at the back of the head and the neck region, and C3 is further below. So the pain will be seen radiating at the back of the head and neck region. That is because of the dura mater inflamed in the posterior cranial fossa. So C2, C3 nerve, and this C2, C3 dermatome will be seen at the back of the head and the back of the neck region. So the answer is clearly option A, the back of head and neck region. So if I may show you, to, like, if this is the so for example, if I just go beyond this point, this is the area which is supplied by the trigeminal nerve branches. But when you look at this posterior region, the back of the head and the back of the neck, it's the dermatome of C2 and C3 nerve which is present here. So if the dura mater is inflamed in the posterior cranial fossa, most likely to have a referred pain in the back of the head and the neck region. Answer is option A. But again, That tells you that innervation of the dura mater has always been important, and it is a question which is worth asking in the future as well. That's the only thing in the cranial cavity innervated. So it makes sense, guys. If the only thing is innervated in the cranial cavity is the dura mater, so whenever you talk about different kind of headaches, that is also because of the nerve supplying the dura mater is elicited. Okay. Moving on to another question, which is once again a repeat question, guys. It's an absolute the copy paste question of one of the previous year the AIMS exam only. That what is the diagnosis based on the given picture? Now, what do you see, guys? Before I discuss that with you, in the first case, you can see both the eye shown in the midline. It's a baseline condition here. In the second picture that you see that there is an abduction in this eye, followed by the adduction in the other eye. That is a conjugate movement of the eye. Of course, when you have a lateral gaze, if I look toward the lateral side, my one eye go for the abduction and the other eye for the adduction. But that is not happening in the third picture. What do you see? What is happening in this image is that the one eye is abducted, but look at this eye that it is still in the midline. It is not moving. What exactly happened? Now, to understand that what went wrong because of which this third condition arises, you need to understand little about this conjugate movement of the eye and how medial longitudinal fasciculus, it does play a role in stimulating the muscle of the other side so that we can have this conjugate movement. So let's have a very quick discussion on this. Look, guys, if let us say if this is the midline, just presume that we are looking at this from above. Here is the, let me just take one eye on this side. Let me take this is on the other side as well. So that muscle for the abduction would be lateral rectus muscle, of course. And the muscle required for the adduction, that is a medial rectus. Now, when I say conjugate movement, that is not the only conjugate movement that looking at one side, but we are going with this example. Okay, let's take an example that let's say this person wants to look toward this side, toward the left side. Like let's say this view is from above and this person wants to look toward the left side. And so what happens that cortex, the cerebral cortex, of course, the cerebral cortex is the one which will send the upper motor neuron. Now these upper motor neuron, they are going to supply the abducent nucleus of the contralateral side, upper motor neuron decussate. So cortex will stimulate the abducent nucleus, and abducent nerve is going to supply the lateral rectus muscle of that side, and that lateral rectus muscle contraction, that is going to cause the abduction in this eye. So, well, one target achieved. But the point is, when this eye is getting abducted, what is causing the adduction in the other eye? Well, guys, it is the white matter bundle which is present in close to the midline of the brainstem, that is called as the MLF, medial longitudinal fasciculus. Now, guys, medial longitudinal fasciculus, because it is present close to the midline of the brainstem, so that's why we call it medial, present longitudinally, and fasciculus means white matter bundle. Now, this medial longitudinal fasciculus, what it is doing, it is connecting the nuclei of both the side. Like third nucleus, fourth nucleus, sixth nucleus, both sides are connected to each other. That is why this MLF bundle. What this MLF bundle is going to do, it is also connecting the sixth nucleus via MLF bundle. It is connected to the third nucleus of this side. And we all know that third nerve is going to supply what muscle? That is medial rectus muscle. And if medial rectus is contracted, there will be adduction. And that's the normal conjugate movement occurring, right? And thanks to the MLF bundle. But let's say, guys, if the MLF bundle is, if there is a lesion here, if there is a medial longitudinal fasciculus lesion is there, if there is a vascular lesion or whatever, because of that, what will happen? The connection between this third and the sixth nucleus will be gone. And if the connection is gone, what will happen? The cortex will stimulate this. This cortex can still stimulate the sixth nucleus, no problem. And the sixth nucleus can still stimulate the lateral rectus. So there will be abduction in this eye. But because now there is no connection to the other side, third nucleus, so this eye is not going to move, and that will stay in the midline. So the picture is going to look something like that. This eye is going for the abduction, and the other eye will stay in the midline, as you can see in the picture. Moreover, now what cortex will do, as a compensation, the cortex will try to overstimulate it. The cortex will keep on firing again and again and again and again. This cortex will keep on firing this sixth nucleus. And because of the overfiring of this sixth nucleus, now still nothing is reaching the other side. We still, medial rectus is not contracting. But because of the overfiring of the sixth nucleus, the eye which is abducted also shows the signs of horizontal nystagmus. This eye will also start doing the horizontal nystagmus also. So horizontal nystagmus is also the sign. So when you ask the patient of this MLF syndrome, which is also called as an internuclear ophthalmoplegia, well guys, why do we call it internuclear? Because the connection between the two nuclei is cut. Now look at the word internuclear, between the two nuclei. So MLF syndrome, or you can say internuclear ophthalmoplegia, one eye which is abducted, other eye stay in the midline, and the one which is abducted, it also starts to do the horizontal nystagmus as well. So for this particular question, it's a repeat question. As I said, I'm sure you read about this MLF syndrome. This is the case of internuclear ophthalmoplegia, or you can say MLF syndrome. Okay. Moving on, the next question, guys. This next question, it is basically about how much you understand about identifying. They give this category picture just to test you that whether or not you can identify the gross anatomy structures at the back here. So no detailed question, nothing about their features or anything about it. It's just 1, 2, 3, 4 labelings are given, and you have to identify them. Well, when you first of all, this picture, it's like a coronal section where a urinary bladder is visible to you. Like this is obviously the urinary bladder there. And before I go to the actual option of 1, 2, 3, 4, guys, just look at this entire image, what you're looking at. The pelvic bone is shown on the side. And look at the muscle which is present on the inner aspect of the pelvic bone. That is the obturator internus muscle, one of the muscle which forms the lateral boundary of the ischiorectal or the ischioanal fossa also. That is the obturator internus muscle. And this muscle which is running obliquely, if at all it was given, this muscle which is running obliquely, that is the pelvic diaphragm. You can say levator ani or pelvic diaphragm. And the reason I'm telling you about this muscle, because this is one of the question asked in the previous year. In the INI-CET only, they've asked this question about to identify the pelvic diaphragm in the section like this here. Though the section was like little more from the posterior side, from exactly like not from this level, from the level of the rectum. But still the pelvic diaphragm is already asked in the question like this in the coronal section. So when you look at the bladder from the back, see, the mark structure 1, 2, 3, and 4, guys. This what is this 1 here? See, the 1 is the vas difference, and number 2, which is passing below that, is the ureter. That is a vas difference, and there is ureter, guys. We generally remember it like water under the bridge. Water under the bridge. When the ureter, it is going to go and enter into the bladder. Now, if this is the bladder here and the ureter has to go inside the bladder, so what will do? It will pass just under the ductus difference or vas difference here. So water under the bridge. Obviously, water is the ureter is having the urine, so it is the water under the bridge. So vas difference, and just below that, passing that, we have what? Ureter. You can even, when you look at the vas difference, I hope you can also appreciate this elevation there. That is the ampulla. That is the ampulla of the ductus difference, or vas difference can be seen. Further below, guys, I don't think this would have troubled you, that this is the seminal vesicle, and well, without a question, that is a prostate gland to be seen from the posterior side. That's a prostate gland. So if I go with this 1, 2, 3, and 4 in this, 1 is the vas difference. So 1 is the vas difference, that is this one. Number 2 is the ureter, that's number 2. Number 3 is the seminal vesicle. There we go. This is, and the number 4 is the prostate gland. There is obviously urethra is not to be seen in this. That is inside the prostate gland. You cannot see it unless the section of the prostate gland is given, right? So it's 1B, 2A, 3D, and 4C. That option C from the given option is the right answer. Couple of histologic questions, guys, and nothing out of the world again being asked. Again, it's about the identification of the structure and more of a anatomy and physiology integration based question in this. The question says, identify the marked arrow in the given image, that the image of the lung was given. Some recall says that it was even a bigger picture where the other parts are also visible, but where the arrow is placed, that was a structure which was given and asked. And the question was, is it a respiratory, terminal bronchial, or bronchus, or atrium? Well, guys, before we come to this image, let me just give you a little overall idea about when you look at the lining epithelium of the respiratory tract. So how it goes, like if obviously, again, I'm taking this schematic picture to explain you. See, if this here is the bronchus, that's the bronchus here. This is the bronchus region. And the bronchus, I mean, it could be the primary, it could be secondary, it could be tertiary, but it is a bronchus. Till the time you keep saying the word bronchus, understand one thing, that hyaline cartilage will be there for sure. If it is a trachea, then you will see a continuous she-shaped hyaline cartilage will be seen. Now, if you see the bronchus, intrapulmonary bronchus will be seen, you will see the pieces of hyaline cartilage. I hope you can visualize this is a hyaline cartilage which is given over there. That's a piece of hyaline cartilage. The lining epithelium in the bronchus, be it trachea, be it principal bronchus or secondary bronchus or intrapulmonary bronchus, the lining epithelium there is so-called respiratory epithelium, and that is pseudostratified ciliated columnar epithelium, guys. The respiratory epithelium, so pseudostratified ciliated columnar epithelium. So whatever is given right from the trachea all the way till the bronchus, it's all pseudostratified ciliated columnar epithelium. When we go further from the bronchus toward the bronchiole, so we have first we have bronchioles, and then eventually we have a terminal bronchiole. So let's say, guys, this is a picture given for the terminal bronchiole. This is a terminal bronchial image which is given. Now notice that in the terminal bronchiole, we do have, like, can you see smooth muscle in that? Obviously, there is a smooth muscle present here, and we do have that smooth muscle, a continuous smooth muscle present in the terminal bronchiole also. And that's why, because there is no cartilage there. So the skeletal framework is not present around that. There is a smooth muscle, and the lumen can be seen very wavy. Look at this wavy lumen that you see inside, and the lining epithelium inside in that region would be, it is a ciliated columnar to cuboidal type of epithelium. Basically, it starts as ciliated columnar, and the more move toward the terminal part, toward the terminal bronchiole, from the initial bronchiole to the terminal bronchiole, the lining epithelium will convert to the cuboidal one. So from ciliated columnar to the cuboidal epithelium can be seen. Simple cuboidal epithelium can be seen. That is, like, by the time we reach the terminal bronchiole. And notice that this time there is no cartilage. The hyaline cartilage was to be seen only till the level of the bronchus. Like, beyond bronchus, there is no cartilage. Well, if we go further more, what you're looking at right now, guys, this is the area of the respiratory bronchiole. That's the respiratory bronchiole which is given there, guys. That's a respiratory bronchiole. Now, in the respiratory bronchiole, what is to be seen? The lining epithelium in the respiratory bronchiole is cuboidal to columnar. It's usually the cuboidal epithelium that you will see here. The smooth muscles are also there. You can see some smooth muscle fibers are also present. But the thing is, you will see it like there's no wavy lumen or something like that. The reason, because in the respiratory epithelium, it's not a continuous smooth muscle that we have. It is disrupted. Why it is disrupted? Because all these out pockets. Can you see all these openings present on the side here, guys? This is one of the identifying feature of that. These are the alveolar. These are alveolar out pockets. These are alveolar out pocket. That's how the air is escaping toward the atrium, toward the alveoli. Alveoli, I'm sure you all know that alveoli are having a squamous epithelium. So you have a cuboidal type of epithelium present in respiratory bronchiole. The smooth muscles are present, but they're broken into pieces because we have these out pockets which are allowing the air to escape. So if you look at the picture, if I take you back, even if you're not able to visualize the epithelium very clearly, guys, you can see, look at these out pockets here. Can you see these, the places the air can escape? That's why it is the respiratory bronchiole is the answer to this here. Had it been the terminal bronchiole, you will see continuous smooth muscle present around them. The epithelium, even if you are able to see the epithelium, that will be the cuboidal epithelium. Bronchus, guys, you already told you that bronchus is having a cartilages and the pseudostratified ciliated columnar epithelium. So there is a respiratory bronchiole, and this again is a repeat question of the exam. Okay, well, another question. This is also a repeat question only. A repeat question from the cells given point of view. I mean, not the repeat language of the question is not repeat, but the image is repeat again, guys. And this is again, they say the area marked in the arrow in the given histopathological image can influence the surrounding cells by. Now, the moment it says that can influence the surrounding cells, in a way we get the answer like in the beginning only. But still, first of all, what you're looking at, but if you look at this picture, these are all serous acinus. These are all serous acinus, and you can see the serous acinus in some of the salivary gland, like parotid gland can have a serous acinus, but obviously parotid gland will not have this lightly stained region, which is an endocrine region of the pancreas, that is the islet of Langerhans. So that's the islet of Langerhans, and guys, islet of Langerhans, it's this lightly stained. It's an endocrine region of the pancreas. The question is that the marked area, the cells which are shown over there, they are basically going to influence the surrounding cell in what way, guys? I'm sure that you all know about this, the beta cells, which are to secrete the insulin, and here's the, let's say, the alpha cells, which are for the glucagon. The beta cells can have a localized effect on the alpha cells, and that is an inhibitory effect, of course, something you must have read about this in the physiology part. And that kind of influence, guys, that local influence that we have is called as a paracrine signaling. Paracrine effect here. It's a paracrine effect or paracrine signaling when the cells are going to affect by their secretions or by their signaling the neighboring cells only, which you can see in the question itself, if it would have said surrounding cell. So the, like, one of the example, like beta cell which are secreting insulin, they can basically inhibit the alpha cell which secrete the glucagon, and that is a effect on the neighboring cell before before these hormones they enter into the systemic circulation. If they would have entered the systemic circulation, would have gone to the liver, then would have been the portal vasculature or portal type of signaling. If there are obviously some autonomic nerves which are supplying this the endocrine region of the pancreas, but that is not the primary mechanism. It's the paracrine signaling which is the main that you have in here. So that again cannot be the answer to this question. And epithelio-mesenchymal transition, guys. Epithelio-mesenchymal transition, when the epithelium is converted into the mesenchyme, it is seen mainly the development, like in the embryology or in the cancer cells. You can see when one kind of cell they transform into the another cell, which are more of a migratory function or the invasive function that you will see for those cells. And then when the epithelial cells is migrating or converting into the mesenchyme. So that is again not to the answer to this question. So if, let's say, the language of the question would have been like this here, then again, even if you don't know about this, you still can answer this question because it says that surrounding cells are influenced by that. That is a paracrine effect here. And otherwise, in the islet of Langerhans, that is a main mechanism in which the beta cells are inhibiting the glucagon secreting cells by the paracrine secretion. Something which I'm pretty sure you must have read about this in detail in your physiology class. But it's all about identifying what the picture is. It is the islet of Langerhans. And when they give if let's say they give you the picture where the parotid gland is given, let's say salivary parotid gland is given to you, I'm sure that this islet of Langerhans will not be there, and you can identify based on that. Because looking at the serous acinus, it is not easy to differentiate between the parotid gland and the pancreas. So I'm pretty sure, and in fact, in the earlier exam also, whenever they gave the slide of the pancreas, they made sure that islet of Langerhans is always shown in that image. Okay, moving on to the next question, guys. That's a question which is, again, I would say ENT surgery based question. It is, a child is planned for a cleft lip surgery. Which of the following muscle is first repaired? Again, if you haven't not read about the surgery of the cleft lip or cleft palate, then I'm still sure that you will be able to answer this question if you apply certain logic. Now, guys, let us say if this is a face, the eye, the nose, and the oral cavity. Now, when you talk about the muscle, well, obviously the muscle which is present around the eye, that muscle is orbicularis oculi. The muscle which is responsible for the closure of the eyeball, that is orbicularis oculi. So we're talking about the cleft lip. Obviously that orbicularis oculi, if it is given in the option, that right in the beginning, that goes out of the picture. That has obviously no role to play in the cleft lip surgery. It's not even close to the oral cavity. Then I'm going with the muscles. Okay? The muscles of facial expression, when you say the facial expression, it is about controlling three things, guys. Either eye, the nose, or the lips. That's your facial expressions. Closing, opening of the eye, elevating your eyebrows, dilating the nostrils, constricting them, elevating, depressing the upper lip, lower lip, stretching of this angle of mouth. So that's a different facial expression. So the muscles, they need to insert into the skin region close to these openings, to the eye, to the nose, and to the oral cavity. Zygomaticus major muscle, one of the muscle given in the option, the reason it is not going to be the answer, because the muscle is going to pull the angle of the lip above, and that zygomaticus major muscle, which is somewhere here, is for the muscle for the smiling and laughing. So that muscle, zygomaticus major, is to stretch its angle of mouth upward for the smiling and laughing. Now we have levator labiae superior. Now levator labiae superioris muscle is to elevate the upper lip. That is a muscle of the upper lip, no doubt about that, because the moment you say the word lip here, this could be the answer which might come to your mind because labia is given. But guys, the muscle which is most primarily needed to be repaired is the orbicularis oris muscle, the muscle which is present all around the mouth, because in the cleft lip, that muscle is disrupted. So it's the orbicularis oris muscle, I'm writing, orbicularis oris muscle is the one which is needed to be repaired first. Generally the skin the skin is dissected, the muscle is exposed, the mucous membrane is also exposed. So that we basically stitch the muscle fibers. We stitch the mucous membrane followed by the muscle fiber. We have to separate the muscle from the mucous membrane first. We have to stitch the mucous membrane, then the muscle, and then obviously the overlying skin. There are different surgeries named to the surgeries also, which I hope you read about them in your ENT class. But the primary muscle which need to be repaired in the case of the cleft lip, whether it's a unilateral or bilateral cleft lip, or even in the cleft lower lip, doesn't matter upper or lower lip, it is the muscle which is surrounding the oral cavity, and that is the orbicularis oris muscle here. So primary muscle which needs to be repaired is orbicularis oris muscle, and that is basically both for the aesthetic region and for the functional region also. That is the muscle need to be repaired, that is orbicularis oris. Okay. And finally, moving on to this question which says that which among the following is not boundary of the hepatocystic triangle, the triangle of Callet? Well, I'm very sure again something which everyone would have got it right, because you read about this triangle in surgery when you talk about the cholecystectomy and all. So guys, let us say if this here is the liver, if I just replicate this, here is the bile duct. That's a CBD, that's a common bile duct. This is a cystic duct, and there's the bladder there. So look, this is basically the triangle, the hepatocystic triangle, where in this hepatocystic triangle, you can see above, in the boundary above, you can see the inferior border of the liver is there. That's the inferior border of the liver. Let me just try to put it from here. That is inferior border of liver. This here is the common hepatic duct. And this here is the cystic duct. So three boundaries. We got a cystic duct, which is present toward the medial side. Laterally, we have a common hepatic duct toward the medial side, cystic duct toward the lateral side, and the roof or above it is by the inferior border of the liver. Cystic artery is the answer to this question, guys. Cystic artery is not the boundary of this triangle; it is one of the content. Now, when you see the branch, like we have the hepatic artery proper entering inside. Hepatic artery, guys, it gives off the right branch of hepatic artery, and it gives off a left branch of hepatic artery. It's the right branch of the hepatic artery which gives off the cystic artery, and that cystic artery is basically the content. It is not the boundary. Cystic artery is a content of this hepatocystic triangle. We also may have an accessory hepatic duct or some major other accessory arteries can be seen inside. Some connective tissue can also be seen. But when it comes to the boundary, it's the inferior border of the liver, the common hepatic duct, and the cystic duct, which are forming the boundary. Cystic artery is a content of the triangle and not the boundary. So guys, this is about the questions of the anatomy part. Now, there was one more question. It was a transverse section of the thorax which was given. And no, this is again, if I have to look at the last couple of years, then this is something which we have to kind of pay a little more attention to. Reading about this little about the sectional anatomy, because especially in the INI-CET specifically, they are focusing on this part, that every alternate year or something, they will give you one transverse section of thorax. But my recommendation to you is, guys, before we read the transverse section of thorax, you need to understand this mediastinal structure from the front view. Like look at the heart from the front, look at where the ascending aorta start, arch of aorta present, descending aorta, at what level the pulmonary trunk is dividing, azygous vein is entering into the superior vena cava is present just right to the aorta, pulmonary trunk will be present just left to the ascending aorta, and then you have descending aorta present more posteriorly. This is like all I'm trying to say, that rather directly going to the transverse section, which is not going to help you identify, because it will be all complete foreign language only. You just have to look at that image from the front first. Schematic, simple diagram. Look at the picture of the thorax from the front. Any image from any book or from the Google. And just visualize that if you draw a horizontal line from that level, that what are the structures you will see here. So if I take a section from the level of ascending aorta, I will see superior vena cava on this side. I will see pulmonary trunk on the other side. If I take the section slightly further below, then I will see the right atrium. I will see along with the right atrium, I'll be able to see the left atrium, which is more on the posterior side, and I will see the ventricle, the right ventricle will be seen, which is leading into the ascending aorta. Again, the thickness of the wall, ventricular wall, obviously left ventricle will be very, very thick, left ventricle wall comparatively will be less thicker. So all these little things that once you understand them, once you visualize these sections from the front only, that if I draw a horizontal line, how this is going to look like, then it will start making more sense about how the structures are present in the transfer section. But in this INI-CET exam, we're still not sure that what exact section at what level it was given. Based on the primary feedback, it seems like that section was taken somewhere at the T6 level, which I believe, but it could be different, guys. It could be entirely different. Could be maybe it's the T4 level or maybe further below. But I believe that based on the feedback that we're getting, that it might be the section at the level of the T6 vertebrae. So this is about the discussion on the anatomy part. You can see there's a number of questions which can be answered from the anatomy, like total of, if I look at the question, we did a recall of around 13-14 questions, and it can go even further if we include those questions as well. And again, you can see not every question is a core anatomy question, like internuclear ophthalmoplegia, the question about the cleft lip surgery, the histology question, which is more of a physiology and histology, correct? So obviously nowadays, especially INI-CET, even NEET also, the questions are asked in a very integrated manner. It's the core anatomy questions are few. Like initial question which we discussed about, like upper limb and lower limb muscle innervation, they are core anatomy questions here. But then majority of the questions are overlapping with other surgical subjects as well. So again, guys, finally, before I conclude this, I would still say the same thing, that the topics which are always been important: head and neck. You saw there are multiple questions from head and neck part. Head and neck, the neuroanatomy, embryology, keep these questions as your priority. In the limbs, they do ask question nowadays about the muscle attachment here and there, but again, nothing can beat the nerve supply. As you can see, there was a question on the on the common peroneal nerve. There's a question asked on the ulnar nerve in hand. So nerve and nerve injuries, it still has to be the primary target in this upper limb and the lower limb here. So with that, we conclude this INI-CET May recall of 2025. And I hope that these questions are going to assist you in the preparation of the upcoming exam. And we'll also get a fair idea about that, what other things we have to focus on for the upcoming INI-CET also. All the best. Keep shining.